Pneumothorax. Occasionally the children may cough for some reason or other, either measles or whooping cough or whatever it is, chronic incessant cough or in a foreign body. It may rupture the alveolus and produce a pneumothorax. Look at the left lung. It's collapsed and there is pneumothorax with the depression of the dome of the diaphragm and shift of the heart and mediastinum to the contralateral side. Say in adults, say in rural areas, most of them are non-vegetarians, they say. And this is, he was eating fish and a fish bone is stuck in the pharynx. And he came to the radiology department. Lo and behold, you see the swallowed air and then widening of the prevertebral stripe. That itself does not mean there is an abscess, but there is something, some inflammatory changes there. And then some of them may be radiolucent or they're radiopaque, so they're so thin you can't find out a fish bone. So what you do is take a piece of cotton, roll it into a small ball, dip it in barium, ask the patient to swallow, and that will get stuck proximal to the foreign body. That's the indirect way of demonstrating that there is a foreign body. Of course, sometimes a chicken bone or something is radiopaque, lateral view of the neck. The AP view of the neck is unnecessary. It's waste of time, money and energy. So whenever you suspect a foreign body, either in the esophagus or in the pharynx, please take a lateral view, and there it is, a chicken bone. Abdomen. What are the emergencies in the abdomen? So far we talked about in the respiratory tract, in the upper gastrointestinal tract, namely in the esophagus. Now we go to the abdomen. Abdomen at one time thought to be a temple of mysteries because the patient comes with a swollen abdomen, some symptoms of abdominal pain, vomiting. There is no other way of making a diagnosis. They used to do laparotomy and then used to treat accordingly. That's why each time they went, whatever their clinical diagnosis may be, they found surprises. That's why some surgeon has described, it was several decades ago, before the radiology and the imaging methods have come practically at a doorstep. Acute abdomen. What is acute abdomen? Sudden onset of abdominal pain requiring emergency medical or surgical treatment. Not only abdominal pain, vomiting, for example. Pain and vomiting. These are the common symptoms of acute abdomen. So you take a preliminary film. You find a radiopaque foreign body in the pelvis. This patient had dentures. His son, who was studying in America, he came one day. He said, "Why don't you have dentures?" And he took him to the town, a dental surgeon, fixed some dentures. Unfortunately, while eating these dentures, he swallowed, and this is the denture set, producing pain and mild obstruction. In children, ascariasis is a common, all over the world. It is one of the common parasites. And then on the plain film, you can see round, emphase round, and cylindrical type of densities through the gas-filled intestines. And occasionally, you may see even a lucency in the center of that cylindrical density. That is the alimentary tract of the worm. That means the worms are still living and kicking and swallowing some air. That's how you outline this. Sometimes they form masses and produce obstruction. They can migrate anywhere. Stomach, small bowel, appendix, biliary tract, esophagus. Another cone down view of the left side of the abdomen, which produces small bowel obstruction with distended bowels, and through them you can see the cylindrical linear densities, which are the roundworms. This child, about 5 days old, born natural delivery of the mother, and having abdominal pain, colic, crying all the time. We took a plain film. There is rounded calcific density in the right lower quadrant, some plaque type of multiple plaques, curvilinear. And this is classical of Meconium Peritonitis. What happens because of the meconium, thick meconium obstructing it, the intestine ruptures. It must have occurred during fetal stage, not after delivery. And here, because it takes some time for the meconium and peritonitis to be localized and calcified like this. And then importance of ultrasonography in the evaluation of acute abdomen. Most common cause of acute abdomen, apart from intestinal obstructions, is appendicitis, acute appendicitis. You can diagnose inflamed appendix, periappendicular collection of pus, abscess formation, localized abscess, and a target lesion. These are some of the imageological findings through ultrasonography. Acute appendicitis, normally they say any visualized appendix must be abnormal. But it's not all the time true, but in general, if you visualize the appendix ultrasound, it must be abnormal because there must be some edema, inflammation. That's why you are visualizing. And you use clinical compression. Of course, there is tenderness. And if you see visualize appendix, if you compress, it is non-compressible. Aperistaltic, and then target on cross section. You see end on, there will be a thickened wall of the appendix, but it should be more than 6 millimeters. Loss of concentric layer. There is a loss, that means there is impending perforation. These are some of the signs of ultrasonography appendicitis. Look at this. Big edema-like lesion, curvilinear lesion, and then surrounding that is the edema, inflammatory appendix. It is end on. We are talking about target lesion. Look at the lumen and the thickened wall, and surrounding it is edema. Non-echogenic area. Echogenic area is the inflamed appendicular wall. Another, abscess formation in the appendix. Appendix, part of the wall is not seen, inferior wall posteriorly, and that means it is perforated and formed an abscess formation. Now we come to the renal colic. Renal colic often is due to a stone anywhere in the urinary tract. And particularly when it is passing through the ureter, you get colic. And 95% of them are fortunately radiopaque, so you can see on plain films of the abdomen. If it is not radiopaque, if the patient has got microscopic hematuria and having a colic, if you suspect, and if there is a history of previous colic because of the ureter calculus, then do an ultrasound. That non-opaque urinary calculi can be identified by ultrasound. This, of course, extensive calcifications of both kidneys and also the left ureter. Often it occurs due to tuberculosis. Although classical tuberculosis of the kidney is putty kidney, but here there are parenchymal calcifications because of the pyonephrosis, stasis, infection, multiple calculi, including the left ureter. Talking of tuberculosis, we said IVP is the minimum investigation you could do at the periphery. And you do an IVP here, microscopic hematuria, pain, a thimble-shaped bladder, chronically contracted bladder with mild dilatation of the right ureter and minimal calictasis on the right side. This is a classical of a tuberculosis. Since tuberculosis is common, of course this could be due to post-radiation or any other changes, but tuberculosis is the common. That so-called thimble chamber is the classical citation in textbooks due to tuberculosis of the bladder. And occasionally, surprisingly, a patient comes with a tension of urine or a pain in the hypogastrium, take a plain film of the abdomen, large, huge calculus in the bladder. Sometimes it is small and speculated. From that you can tell the component, the crystal component of the calcification of the bladder stone. Small stone at the uretrovesical junction, because if it is a ureter, it should be linear. It is horizontal. That means it is at the left uretrovesical junction. And to prove that, you can do an ultrasound easily, and you could see the echogenic lesion in the bladder at the junction of the ureter and bladder. And as I said earlier, accidents are also common in the rural areas. Pelvic injuries are common, and this is the rupture of the bladder, retroperitoneal rupture of the bladder. Generally, this is associated with fractures of the bones of the pelvis. Here you can see the fractures of the ischiopubic junction and superior ramus of the pubis, and of course, contrast is going out of the bladder into the retroperitoneal area. Usually, how can you just say that it is not intravesical or intraperitoneal rupture, but a retroperitoneal rupture? Because intraperitoneal rupture goes freely into the peritoneal cavity and outlines the walls of the intestine, whereas here it goes into the intermuscular planes and are linear. And perforation. Peptic ulcer is common, particularly in rural areas. Why? Because partly due to malnutrition, partly due to the spicy food, partly hypoproteinemia, and of course, most importantly, Helicobacter pylori infection. And then perforation, if you suspect perforation, you should take a film in the erect posture. If the patient cannot stand, at least in the sitting posture, so that the free gas in the peritoneum rises to the level of the diaphragm. On the left side, anyway, the gas in the stomach and colon may obscure the free gas under the dome of the diaphragm. So, on the right side, it's clear. Between the liver and the dome of the diaphragm, a curvilinear gas shadow, perforated viscous. Sometimes the patient may not be able to even sit up, in which case you make him lie down on the left side, raise the right side, and all the gas, free gas, goes up, and then it is entrapped between the liver and the abdominal wall. The perforation may be, for example, posterior duodenal ulcers, maybe retroperitoneal, and then gas goes along the kidneys, outlining along the solar shadows. It is the perforation retroperitoneally of a duodenal ulcer. The patient is taking a chunk of meat with bone and unfortunately swallowed. Cough, 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 and the esophagus has ruptured. What are the signs on a PAV of the chest alone? Well, first history is important. And then the superior mediastinum is widened, and the tracheal shadow is obliterated in the lower area. That is because of the dilated esophagus. And there is effusion. It has ruptured into the pleura. Effusion. Occasionally you may find even a gas shadow along the para-aortic area. Mediastinal emphysema also you may see. This is ruptured esophagus. And then perforation or intestinal obstruction, acute abdomen. You take routinely you take a supine view and erect view, and sometimes decubitus lateral views. And in this particular case, we can outline the gas in the stomach. But if you look carefully, in the right upper quadrant, there is air in the biliary tract. Why? Why is there air in the biliary tract? Commonly due to gallstone ileus. The gallstone gets through the common duct and obstructs somewhere the intestine, commonly the duodenojejunal flexure, and thus air enters into the biliary tract. And of late, any surgery, laparoscopic or otherwise, or ERCP, any manipulation of the sphincter of Oddi, you can get gas in the biliary tree. But commonly, posterior duodenal ulcer, perforation to the common duct, is one of the common causes of air in the biliary tract if there is chronic peptic ulcer history. This is one of those. And then an accident, rupture of the dome of the diaphragm. Look for the ribs, that's important. Here, what you see like a dome of the diaphragm is not the dome of the diaphragm. It is the outlining of the stomach. That means the stomach has herniated through the rupture of the dome of the diaphragm. gastrointestinal tract obstructions. First, the stomach, volvulus of the stomach. A lateral view is important. The stomach wall, you could see, and the lesser curvature and the greater curvature is outlining. A little contrast was given by mistake, but actually whenever you suspect obstruction, never give a contrast, even if it is water soluble. Maybe half an ounce you can give just to be sure and to note where the obstruction is and what type of obstruction it is. Volvulus of the stomach, there are 3 varieties of volvulus of the stomach, but this is one of the manifestations. And then small bowel obstruction. Frankly, whenever a clinician or a surgeon comes across an intestinal obstruction, particularly the small bowel, immediately he passes a tube. And this is, look at the air fluid levels in the jejunal area. And whenever there is small obstruction, you have to think in your own terms. Is it complete or incomplete? It is an incomplete if there are some gas shadows beyond the distended loops of bowel and in the colon. Then you are sure it is an incomplete small bowel obstruction. There are several causes. For example, a strangulated hernia, inguinal hernia, can get intestinal obstruction. Or adhesions, most common cause of small bowel obstruction is adhesions, either due to previous operation, surgery, or due to previous history of peritonitis. Classical small bowel obstructions, where is the obstruction? The air fluid levels are all the way going up to the right lower quadrant. That means the obstruction is at the distal end of the ileum. And then, of course, you don't have to do a bare minima to rule out colonic obstruction because all these air fluid levels are in the small bowel. You can tell because the jejunum, there are valvulae connivantes vertically going, and in the ileum, they're smooth. There are no valvulae connivantes. Another small bowel obstruction, but then the stomach is distended, and maybe part of the colon also will be seen. Mere air fluid levels they do not mean small bowel obstruction. Majority of the time, it is. But sometimes, even in paralytic ileus, you can get. How do you differentiate between obstruction and paralytic ileus? Look for the stomach. Stomach is distended in paralytic ileus. Colon is also distended in paralytic ileus. And then small bowel distension with air fluid levels. This is a case of perforated appendix with paralytic ileus simulating small bowel obstruction. But then maybe perforated appendix formed a localized abscess and producing really partial obstruction of the terminal ileum. Look at the change from the pattern of small bowel obstruction to the pattern of large bowel obstruction. Look at these are not valvulae connivantes, these are hostile markings. How can you differentiate? Valvulae connivantes are thin, delicate, and the space between one and the other is small. Not only that, they run from wall to wall, whereas here, hostrations are thicker, they stop short of the lumen, and they are wide-spaced. And look at the markedly distended cecum, hepatic flexure, transverse colon, part of the descending colon you see, and beyond that, you don't see any gas. That means the obstruction is at the descending colon. Maybe carcinoma, whatever is commonly is carcinoma in the elderly, but otherwise also diverticulitis, etc. You can get partial colonic obstruction. But then look at the cecum, it's markedly distended. If the ileocecal valve is competent, the cecum gets distended and may get perforation also. If it is incompetent, then most of the gas is deflated from the cecum and colon, goes into the small. Hematemesis, another acute emergency. Common cause is because you see alcoholism is rather rampant in rural areas, cirrhosis of the liver and esophageal varices. Look at the worm-like serpiginous type of filling defects, linear, curvilinear, end-on, classical of esophageal varices. A little barium swallow would help. And then this patient is a diabetic, chronic diabetic. He developed some lung infection, and this is the dysphagia he developed also, along with lung infection. Colonies of candidiasis. Frankly, if you ask the patient to open the mouth, you can see white patches on the tongue. Esophagus, multiple, simulating esophageal varices, but note the difference. Those varices produce thicker, curvilinear, whereas these are the colonies of candidiasis producing multiple filling defects. Gastric ulcer, benign gastric ulcer. Today, gastric ulcers are a little less than duodenal ulcers. And this ulcer is along the lesser curvature, because lesser curvature ulcers are common. And it's a benign ulcer. How can you tell it's a benign ulcer? It is penetrating ulcer into the wall. Maybe it may perforate into the lesser side. So it is classical of a benign ulcer. The mucosa are going into the floor of the ulcer crater. That is important. Whereas malignant ulcer, look at the irregular, thick rind along the ulcer crater. And the ulcer also huge. Benign ulcers, you can get large ulcers, but not this huge and irregular wall. And it is in the lumen with a mass, intraluminal, whereas the other one was going out into the wall. Duodenal ulcer, acute duodenal ulcer, cause of hematemesis. Look at the pea-sized double density in the duodenal bowel. Not only give contrast barium, occasionally you can give some, ask them to swallow, say, or drink a soda which contains a lot of gas, and you can get almost a double contrast strip. And in children, pain in the abdomen, particularly the lower quadrant, interception, ileocecal interception. Do you bear in mind? Ultrasound also helps, like a target sign, I'll show you. But here, you see, give a barium enema, and you see harmonica or a coil spring appearance in the cecum, classical of ileocecal interception. Occasionally, if you raise the barium enema can, you can introduce pressure and you can reduce also on the spot. This is what I was talking about, the target sign with ultrasound. Look at the echogenic center and the non-echogenic periphery, classical of interception. Gallstones, they are also common in the rural areas in spite of their diet and all that. But then you do an ultrasound. Today nobody does cholecystography. Years ago we used to ask the patient to swallow certain tablets in the previous evening and then thus visualize the gallbladder. But today ultrasound is good enough. With stones or without stones you can get cholecystitis, and these are the multiple stones in the gallbladder. Whether they are opaque or not, still this is a classical appearance of gallstones. And then what are the emergencies in the musculoskeletal region? Already we mentioned about fractures. Head injury, look at the orbital plate, linear lucency, head injury. Simple lateral view of the skull or AP view of the skull is good enough. Not that fracture itself is dangerous. The important thing is the contents of the skull, the brain. Is there injury to the meninges? Is there injury to the brain? That is important. That's why today, if the patient gets an injury, don't take the skull and say, oh, there is no fracture and leave him alone. The signs are important. Follow the patient. You may have convulsions, headache, edema of the eyes. So at that time, you have to have a CT. CT is essential to rule out any injury to the dura, a subdural hematoma, or a brain injury. Contusion of the brain, laceration of the brain. And then in spine, jumping from a wall, for example, compression fracture. A fracture is not that important as the fragment protruding to the spinal cord and producing paraplegia. These are all the preliminary screening. Another common injury is dislocation of the shoulder. Look at the loss of parallelism between the glenoid rim and head of the arterial margin, the head of the humerus, shoulder dislocation. And sometimes the patient may complain of acute back pain because of the previous injury. This is healed compression fracture, which occurred a long time ago. He realizes that. But now he has had a mild fall and he complains of pain. You have to differentiate between old injury and acute injury. And then in children, slipped epiphysis is another, because they play games or native games or whatever games, slipped epiphysis is common, and by drawing the lines, always, most of the time, the physical line is wide on the slipped side. And also the epiphysis goes down, and that gives rise to the diagnosis of slipped epiphysis. And because most of them are manual workers, hard workers, you can see fracture of the scaphoid bone. That's also not so unusual. Knee injuries. And sometimes you may find no fracture on AP and lateral of the knees, but if you take a decubitus lateral, look at the arrow. There is a fat fluid level. That means there is a microfracture, or there is injury to the fat, or injury to the bone marrow. That's why you find the fat fluid level. Of course, here there is no problem. Fractures of the lower ends of the both bones of the forearm. Here, there is a fracture, but it's impacted fracture. That's why you get a double density in the middle of the calcaneus. Just because there is no translucent line, it doesn't mean there is no fracture. Same thing in the depressed fracture of the skull. A double density produces, think of a fracture. Supracondylar fracture, not so uncommon. And then acute fever, high temperature, swollen thumb, pain. And this is not injury, but it is osteomyelitis. Osteomyelitis, look at the edema, look at the destruction of the proximal phalanx, and then already some sequestration is formed. But still they may come as acute pain. And sudden pain in the back and paraparesis symptoms, AP view, bilateral paravertebral soft tissue swelling. Unless you take a lateral view, you can't diagnose it as tuberculosis of the spine. This is not so emergency, but it's commonly encountered in the rural area. Chronic fungal infection, either actinomycosis or motheromycosis, or a combination of organisms. There is the classical chronic osteomyelitis, periostitis, irregular cortical thickening, multiple sinuses, mycetoma of the foot, or so-called Madura foot. Now, another important thing when you are practicing in rural areas is how best, because most of them are poor, illiterate, and some of them may not have a job. Only seasonal jobs they have whenever the crops come up. So cost-effective radiology, you have to practice. And what are the principles? First of all, talk and listen to the patient. Develop communication skills. Not as soon as the patient comes with a swollen arm and leg, take a radiograph. Talk, you are a clinician too. And consent from form you have to get signed today, medical legal case and all that. Explaining all the details to the illiterate. Clinical examination, although you are a radiologist, still you are a clinician first. You have got your MBBS first, then only your MD or DMRD in radiology. So talk to the patient and find out, make a clinical diagnosis, and then try to correlate with the radiological findings. If there are old films, look into old films, because supposing there is a patch in the lung, immediately don't think it's an acute type of tuberculosis. It may have been there for years. He may have been treated with tuberculosis. It may be fibrotic, a lesion. As I said earlier, communicate with the clinician too, not only with the patient. The clinician, because the clinician has examined thoroughly and he has got at hand laboratory findings. This sputum is positive for aspergillus. So immediately you can correlate all the patchy findings in the chest radiograph. You can correlate it's the aspergillus. So always communicate before writing all the one-page differential diagnosis or committing to a definitive diagnosis. And also deal with medical legal problems, particularly the fractures. Take details. Although you are a radiologist, keep the films in a safe box. You shouldn't give it to the patient or the clinician.